Okay, so good afternoon, everyone. We are today here for this session called EPC Exchanges in Primary Care, where we have people who are working in different aspects of primary care come here and share their work, share their learnings, share things which might be useful to people who are actually working on the field. And it is happens in a very informal session. We do it on first and third Saturday of every month. So today we have with us Anupama ji from Reach India. She has been working with TB for quite some time, and they have been working with the TB Champions movement, where patients who have suffered from TB and recovered from them. From the same, they come forward and help other patients and families suffering from TB to seek care, to sustain care, and also to ensure that more and more people become TB champions. So, and they have been working on this in many parts of India and different states of India. So she will talk about their work, and she will talk also show us some interesting videos which would be very useful to us. So without taking much of the time, I'll hand it over to Anupama. Please over to you, Anupama. Please take it on.
Thank you. Thank you so much, Sham. I just want to confirm if you can see my slides.
Yes, it is
Are they
visible.
full, Arpita, are they full screen? Not yet, no?
Not yet. No.
No.
1 second. Let's just get it up full screen and then. Now?
Yeah, you
No, you
can
can
make it.
just,
Yeah,
yeah,
yeah.
now we can see it.
Yeah.
All right, great. Good afternoon, everyone. And it's my pleasure to be here as part of this Exchanges in Primary Care session. Thank you so much to Sanjana, Sham, the entire BHS team for inviting me and for this opportunity. I must confess, because I'm sharing slides, I can't really see any of you. So if at some point anyone wants to ask a question or say something, please just go ahead. So a little bit about myself before I get to talking about the TB champion movement. I start by saying I'm not a doctor. I wandered into public health by accident, you could say, back in 2007-8 when I began working on HIV. In 2010, I joined REACH, and I'll tell you a little bit more about the organization. And I've been there since. So it's been 16 years of working on many different aspects of TB. But I must say, of everything I've worked on in the last 16 years, this TB champion work has probably been the closest to my heart personally. And I'll tell you a little bit more about why. I have slides organized into three phases in which I want to tell this story. I'm happy to pause at the end of each phase to take questions, comments, reflections, anything. But if, as I said, since I can't see all of you, if anyone wants to say anything at any point, please feel free. All right, so we are a 27-plus-year-old organization in the fight against TB. We began specifically at the time when the revised National TB Control Program was being rolled out in across India and in Tamil Nadu. We're headquartered in Chennai, and we came into being as an organization that would act as an interface between the RNTCP, as it was called at that point, and the private sector. I think many years ahead of PPM models and so on. At that point, the founders, Professor M.S. Swaminathan, Dr. Nalini Krishnan, and a group of like-minded scientists, social scientists, leadership from the Tuberculosis Research, TRC, as NIRT was then called, came together and set up REACH, and we really began working as a public-private interface agency. In 2023, we observed our 25th anniversary with a public oration by Dr. Samya Swaminathan on health equity. And in 2024, at the end of our 25th year, you could say, we bookended it with a second oration by Professor Madhukar Pai on the no-do gap in TB. So broadly, very quickly, I'll say as an organization, we have four priorities. We work very closely with communities, which of course I'll speak more about today. We provide both direct care and support, and we facilitate care and support to people with TB and NCDs. In Chennai specifically, we run a network of about 30 to 35 what are called nakshatra centers. They're centers set up in private or community hospitals in the city that provide free high quality TB care by working as a bridge between the national TB program and people seeking care in the private sector. This has really been at the core of what we do. Every year we provide support to over 3,000 people with TB in the city of Chennai, and we continue to do this. Over the years, we've also expanded to a more sort of multi-sectoral approach, working with the media and journalists, working with elected representatives, working with industries, and so on. And through all of this, what we're really trying to do is to improve public understanding of TB and NCDs. Since 2018, we began working on NCDs as well, first as a uh, through a TB diabetes intervention, and today we also work on TB and chronic respiratory diseases, hypertension, and a range of different non-communicable diseases as well. So that's very briefly about what we do. Today, our footprint is across several states in the country. We've previously worked in about 20 plus other states as well. So Tamil Nadu, Bihar, where a lot of our work happens, as well as UP, Uttarakhand, Jharkhand, and so on. I'm not going to get into the details of all of this. Happy to share later. So let me begin by really talking about what the genesis of this TB champion movement is. And I think it goes back to our own beliefs and ethos as an organization, which have always been that we have to put the patient at the center of everything we do. And therefore, that means we have to listen to what is working for them, what is not working, what we can do better. And we really, even in the care we provide at the Nakshatra centers today, we continue to be driven by this. And therefore, not surprisingly, one of the things that had always really been on our minds was why is it, unlike, say, HIV, obviously, the obvious example, or several other areas, why is it we don't have um, the active involvement of survivors and advocates in TB? Why is that? Why is that silence so loud, really? So, in the first phase, 2016 to 2020 was when we really introduced a movement and established the identity. And our starting point, like I said, was twofold. One is despite the fact that we all know that TB is really a socio-economic disease, our responses really focused on the more biomedical aspects, which meant that while we could treat the disease and diagnose the disease, there's so much more that we were not addressing. Secondly, like I said, TB survivors were not really engaged. We had maybe a handful of strong TB advocates who would come and speak at meetings, but really there was no structure beyond that. So I think our starting point was these two questions. How do we broaden the conversation around TB from a purely clinical lens to a more socio-economic lens? And how can TB affected communities, whether it's people with TB, it's TB survivors, it's family members who've lost people to TB, how can they participate meaningfully in the collective response to TB in the country? So we began by designing a few interventions that I'll briefly describe in that phase. First was, and at this point we had just begun working in 6 states. This was Bihar, Jharkhand, Orissa, UP, Chhattisgarh, and Assam. And this was through then USAID support. And in each of these states, we identified about 30, 40 TB survivors. We organized what we called TB Survivor to TB Champion workshops. After the training, and I'll talk a little bit about the curriculum and what that was like. After the training, these TB champions participated in what we called a mentorship program, where basically over 6 months they had a set of XYZ things that they could do in their communities, and that was really important to us. We defined their sort of area of action as their local space. In that period, we also helped TB champions come together to form survivor led networks. Today, there are 15 plus networks at the state level in several states. And we really look to try to create opportunities for TB champions at many different forums. So 1718 was the first TB survivor to champion workshops that we did. And I think for all of us at Reach, no, we were also learning at that point. It was really trial by fire, as they say. And I think we were just in awe of the fact that here were people who had no clue who we were, trusted us, came to a workshop, spent 3 whole days with us. And one thing that every single person said, this is the first time I'm meeting someone else who's had TB. And I think that really for us summed up the loneliness of what this TB journey is like. No, the fact that there is no peer support, that these networks don't exist, that people can't rely on others to say, okay, I really don't know what to do in this situation. So I think those first set of workshops really sort of validated for us how necessary this was. And immediately following these, TB champions began working with their communities for the first time. And I think this was really a mixed bag because we had a lot of discussions internally. You know how you plan projects and you plan and plan and plan, and then what happens, happens anyway. So, what is it they could do? Do they provide peer support? Do they sit at facilities? Do they educate their communities? So really, we tried several different things. And one big aspect of this was really promoting that TB champion identity. So you can see in that photo on the right extreme, we made these individual personalized banners for each TB champion with the symptoms of TB and their own photo that they use because I think for us, we wanted to promote that idea that no, this is nothing to be ashamed of. That yes, I had TB, I've recovered from it, I'm not ashamed to say it. And that was really, I think, the starting point for what a lot of the early batch of TB champions, how they established themselves in their own communities. As I said, this was also when the first survivor-led networks got formed. Um, on the right side, this is, as you can see, the Orissa Kalinga TB Survivors Network. Bottom left is the founding members of TB Mukt Vahini in Bihar. And top left is a meeting between the state TB officer of Jharkhand and the governing body members of TEJ, the Jharkhand network. And I'll speak a little bit towards the end about how these networks are doing today. But what we did in that first phase was really help them come together, help some of them who were interested get registered legally as societies or trusts or however they felt, and really help them through that initial governance and paperwork and so on. So, what happened by the end of this first phase? I think the most important thing in some ways was that this curriculum got developed. We trialed it through the workshops, and then the National TB Elimination Program formed a working group, and we worked together to actually put it down on paper, and it was formally adopted by the NTEP. And I think we began to see the language of engaging TB champions get reflected in different documents, whether it was the National Strategic Plan that was being developed at that point for 17 to 25, or the joint monitoring missions discussions. And I think for us, one of the things we really focused on is how do we get TB champions on as many different platforms as possible. Bottom right was the first India TB Summit at that point in 2018 March, when I think was the first time the Prime Minister attended a TB meeting in my recollection. And that was when I think it really changed political will, the commitment for the program in the country. And you can see Sudeshwar from Bihar, a TB champion, speaking at the meeting. Left is Himani from Chhattisgarh, speaking at the Union Conference that was in Hyderabad in 2019. And on the top right are 5 TB champions with health officials from Bihar speaking at our first dissemination meeting. So we really wanted to get to the point when, frankly, they were comfortable sitting on a stage like that next to senior health officials. They could speak in front of the Prime Minister. They could speak at international conferences and really have that identity of TB champions established among everyone. And if you ask me today what were sort of the takeaways from that first phase, I think it was that we were able to successfully establish this identity. We were able to show that TV champions were highly motivated. One of the things people had said to us is, this is not like HIV. People are not living with the disease. It's not a chronic disease. They get cured. They'll want to move on with their lives. But I think we were able to show that's not the case. And even today, you ask any of the thousands of TV champions what their motivation is. And I've now heard this answer from hundreds of them, literally. It's very simply that no one else should suffer like I did. And I think that's really the core of where this motivation comes from. And we learned that that has to be supported with both monetary incentives. I'll talk a little bit about that, and training. They became recognized as leaders within their communities, and they really became the person someone in that area went to for anything. And we saw this during COVID as well, when people didn't know what are these vaccines that are coming in, why should we wear a mask, why should we not leave the house? And organically, our TB champions began to play such a big role in that period, just helping people navigate health systems. And this process itself was a really empowering one for the individual. A lot of the TB champions we worked with reported that not just their knowledge of TB, but their overall skills, their public speaking, their ability and confidence to go walk up to a panchayat leader, walk up to an MLA, to an MP, and talk to them and advocate for TB. And as a result, their overall social standing, how people in the community perceive them, all of these dramatically improved. And as a result, we feel that trust in the health system and community willingness to really engage with TB services became much better as well. So at the end of this first phase, we also created several resources. I'll share links at the end. And we wanted to document some of these early stories as well, just so both in terms of photos, in terms of written documents, in terms of videos, just so, I mean, for someone who says, who is this TB champion? No, we had a story to show them. And on that note, I just want to show you a short video. One, one moment. Just need to share screen again.
ମୁଁ ଜଣେ ଓଡ଼ିଶୀ ଭାରତନାଟ୍ୟମ୍ କୁଚିପୁଡ଼ି ଡ୍ୟାନ୍ସର ଥିଲି। ରିପୋର୍ଟରେ ଆସିଥିଲା ଯେ ବ୍ରେନ୍ ଟିବି ଅଛି ବୋଲି। ସେତେବେଳକୁ ମୋର ପ୍ରାୟ ୱାନ୍ ସାଇଡ୍ ଗୋଡ଼, ହାତ, ଆଖି ସବୁ ଗୋଟେ ଗୋଟେ ପାର୍ଟସ୍ ମୋର ଲ୍ୟାପ୍ସ ହେଇଯାଇଛି। ମୁଁ ତା ପୂର୍ବରୁ ଟିବି ରୋଗ ବିଷୟରେ କିଛି ଜାଣିନଥିଲି, ହେଲେ ମଧ୍ୟ ଖାଲି ଶୁଣିଥିଲି ଟିବି ଗୋଟେ ସଂକ୍ରାମକ ରୋଗ, ସେ ରୋଗକୁ ବହୁତ ଲୋକ ଘୃଣା କରନ୍ତି ବୋଲି ଖାଲି ଶୁଣିଥିଲି। ସ୍ତ୍ରୀକୁ ଯାହା ଅସୁବିଧା ହେଲେ ସ୍ୱାମୀ ସପୋର୍ଟ କରିବାର ଅଛି, ସ୍ୱାମୀକୁ ଯାହା ଅସୁବିଧା ହେଲେ ମଧ୍ୟ ସ୍ତ୍ରୀ ସପୋର୍ଟ କରିବାର ଅଛି। ମୁଁ ଏଥିରେ ମଧ୍ୟ ମୁଁ ଲଭ୍ ମ୍ୟାରେଜ୍ କରିଥିଲି। ମୋ ହଜବେଣ୍ଡ ମୋତେ ବହୁତ ସପୋର୍ଟ କରିବା କଥା ଛାଡ଼ିକି ସେ ମୋତେ ଟିକେ ଘୃଣା ଷ୍ଟାର୍ଟ କଲେ। ପ୍ରାୟ 15 ମାସ ପରେ ସେ ମୋତେ ଟିକେ ଟିକେ ଘୃଣା କଲେ। ତୋତେ ଟିବି ହେଇଛି, ତୁ ମୋ ସହିତ ରହନା, ତୁ ମୋ ସହିତ ଖାଇବା ପିଇବା କିଛି କଲେ ବୋଲି ମୋତେ ଘୃଣା କଲେ। ସେଥିରୁ ମୋ ମନ ବହୁତ କଷ୍ଟ ହୋଇଗଲା। ତାପରେ ମଧ୍ୟ ମୋତେ ଆଉ ଭଲ ଲାଗିଲାନି। କିନ୍ତୁ ଫାର୍ଷ୍ଟରେ ମୋର ବାପା ମା ମୋତେ କହିଲେ କି ତୁ କିଛି ଟେନସନ୍ ନେନା, ତୁ ବହୁତ ଶୀଘ୍ର ଭଲ ହେଇଯିବୁ, ତୁ ଖାଲି ଭଗବାନଙ୍କୁ ଡାକେ, ତୁ ଭଲ ହେଇଯିବୁ ବୋଲି। ବହୁତ ଲୋକ ଟ୍ରେନିଂରେ ଥିଲୁ ଆମେ। ଟ୍ରେନିଂରେ କାହାର କ'ଣ ଟିବି, ଯାହାକୁ ଟିବି ହେଇଥିଲା, କାହାର କ'ଣ ଲକ୍ଷଣ ଥିଲା ସବୁ ପଚାରିଲେ। ହେଲେ ମୋତେ ବ୍ରେନ୍ ଟିବି ହେଇଥିଲା, କିନ୍ତୁ ମୋତେ କିଛି ଟିବିର ସିମ୍ପଟମ୍ସ କିଛି ମୁଁ ଜାଣିନଥିଲି। ମୋତେ ସେ ସିମ୍ପଟମ୍ସ କିଛି ଆସିନଥିଲା। ସେ ଟିବିର ସିମ୍ପଟମ୍ସ ଆଉ ଟିବି ହେଲେ କ'ଣ କ'ଣ ସବୁ ଆମକୁ କରିବାର ଅଛି, ଲକ୍ଷଣ ଯଦି ଥିଲେ ଆଶା ଦିଦିଙ୍କୁ ମିଶିବାର ଅଛି। ମୁଁ ଭୁବନେଶ୍ୱରରେ ଟ୍ରେନିଂରେ ଆଉ ବହୁତ ମିଟିଂରେ ଆଟେଣ୍ଡ ହେଇଛି। ତାପରେ ଦିଲ୍ଲୀରେ ବହୁତ ବଡ଼ ପ୍ଲାଟଫର୍ମରେ ହେଲ୍ଥ ମିନିଷ୍ଟରଙ୍କ ପ୍ରୋଗ୍ରାମରେ ଟିଭି ହାରେଗା ଦେଶ ଜିତେଗା ପ୍ରୋଗ୍ରାମରେ ଆଟେଣ୍ଡ ହେଇଛି। ସେଇଠୁ ଆସିଲା ପରେ ଆମର ଗାଁରେ ବ୍ରହ୍ମପୁରରେ ମୋତେ ବହୁତ ଲୋକ ଚିହ୍ନିଲେ ମୁଁ ଟିଭି ଚାମ୍ପିୟନ ବୋଲି। ବହୁତ ମୋତେ ରେସ୍ପେକ୍ଟ ଦେଉଛନ୍ତି। ସେଥିରେ ମୁଁ ଆଉ ମୋ ଫ୍ୟାମିଲି ସବୁ ବହୁତ ଖୁସି ଅଛୁ। ପ୍ରଥମେ ମୋର ଗୋଟେ ସ୍ୱପ୍ନ ରହିଲା ଯେ ମୁଁ ପୂର୍ବରୁ ଯେମିତି ଡ୍ୟାନ୍ସ କରୁଥିଲି ମୁଁ ସେମିତି ଫାଷ୍ଟ ମୋର ହେଲ୍ଥ ଠିକ୍ କରିକି ମୁଁ ଫାଷ୍ଟ ଡ୍ୟାନ୍ସ କରିବି। ତାପରେ ମୁଁ ଏବେ ଯେଉଁ ଟିଭି ପ୍ରୋଗ୍ରାମ୍ ସବୁ କରୁଛି ସେମିତି ଟିଭି ପ୍ରୋଗ୍ରାମ୍ସ କରିବି, ଲୋକମାନଙ୍କୁ ସବୁ ଟିଭି ବିଷୟରେ ବୁଝେଇବି, ସବୁ କରିବି। ଆମେ 2025 ସୁଦ୍ଧା ସାର୍ କହିଲେ 2025 ସୁଦ୍ଧା ଆମେ ଟିଭି ରୋଗକୁ ପୁରା ଆମ ଭାରତ ଦେଶରୁ ନିର୍ମୂଳ କରିଦେବା। ଟିଭି ହାରେଗା, ଟିଭି ହାରେଗା, ଟିଭି ହାରେଗା, ଟିଭି ହାରେଗା।
You know how everyone always has favorite children, although you're not supposed to technically. I think Chinmay was one of my personal favorites. And I think let me just stop here and any quick questions, reflections. I am keeping track of time. If not, I can move on to the second phase.
Maybe just one quick question, Anupama. One challenge that we see here is in taking the talking of the word TB. When you say that the champions, they shared their journey, was it difficult? Did they also have such hesitations? And what was done for that?
They did have, some of them did, and I think more the women in particular did have these hesitations that if I tell everybody about it, even though I'm cured now, right? I no longer have the disease, will there be any backlash against the family? But I also think what happened is because they became, for lack of another word, useful to their communities. They became the source of knowledge. And that's where I think that shift happened from shame, embarrassment, fear to being proud. And they were able to make that shift. I'm not saying it was easy. I know I do know anecdotal examples of people who said, I don't want to work as a TB champion anymore because no, my family is not comfortable. And of course, we always respect those decisions, right? I mean, we don't know what people are going through in their settings. But I think by and large, the empowerment process, if I sounds a bit patronizing to put it that way, but I think just that whole journey was enough to sort of drive away some of those hesitations. And I mean, I'm not saying they won't be there ever, they will. But I think that's really what we saw, that over time, no, that hesitation of sharing the TB stories really sort of went away. I can see Sham has his hand up as well.
Yeah. So my question was that once you identify someone as a TB champion, what is the kind of engagement which that person does with another patient? Like, how do they become? How do they communicate with other patients? How frequent is the contact? And what are their roles after they are designated as a TB champion?
You've given me the entry to phase two, which is what I really wanted to talk about.
Okay,
Let me
okay,
answer
sure.
that first question, which is we've experimented with different models of how this works. We've done facility-based, where through partnership with the TB program, we have a TB champion placed at the facility. Of course, we have to be careful about masking and reinforce no precautionary behaviors just to prevent reinfection as well. So we do have to sort of keep emphasizing that constantly. We've had where we do home-based visits. That's one model to do. We've tried with the phone, but frankly, we found the rapport is not there. When some random person calls you on the phone and says, "Make TB champion ho," I mean, what does it even mean? Unless you've met somebody in person and had an opportunity to build that relationship. So phone is really something that we've used in terms of follow-up, but we try and insist on a first in-person interaction as much as possible. Let me just move on to I just want to move on to the second phase, which is really talking. I'll come back to or maybe I will talk briefly about the curriculum actually before answering your question, Sham, about the roles. Arpita, you can see my screen, right?
I can.
Yeah, thanks. So very briefly, the TB Survivor to Champion curriculum was is in 5 modules. The first is really looking at the TB science and getting that basics right, because one thing we realized very early is just because someone had TB, it doesn't mean that they know all the basics, right? No, and like what Chinmay said, forget extra pulmonary TB. That's a whole other ball game and so much more complicated. But even in terms of transmission, in terms of contact tracing, so many things. And now today it's so much more complicated because we're talking about subclinical TB where there are no symptoms. So really making sure those basics are right. Understanding the TB burden and the response, and particularly how the program functioned. The NTP is among our more robust vertical public health programs, and really understanding what services were available at what level was really important. The third module focused on the TB care cascade, and I think this was really the most important, which was one, allowing them to come together to share their own stories, and two, what we called pathways to cure or the care cascade, where really they looked at from the point someone develops symptoms or is screened for TB right through till life after TB. At every stage, what had been their own experience, what had been their challenges. And this helped identify advocacy opportunities, areas for action really for the TB champions. And module 4, which I talk about, is really focusing on their role, on different ways in which they could support people with TB and drug resistant TB, whether it's advocacy and so on. And finally, looking at survivor led networks. So, if you look at our second phase of 2020 to 24, it was really what was the role of a TB champion? What is it they could do? That was really the question that we asked ourselves. And I think over these 5, 6 years, it sort of organically developed into 5 things. As TB champions today, if you look at it, I think one of the biggest, most tangible aspects of what they do is supporting people with TB, providing peer support, providing treatment literacy, which, to be very honest, in a very overburdened health system, who has time to spend, in explaining everything and being that emotional support, that person who can be called when there are questions in the family. This is Anjana on the left from Bihar. Um, and she gets 5 phone calls on average every day from various people with TB in her community who have so many questions. And I think the biggest role that TB champions have been able to play is helping people answering these questions. Like I said earlier, they've done this either by being positioned at the health system. We've defined in our projects, and I'll briefly explain this later. Let's say in a month, depending on the caseload of a facility and what we felt was feasible, a TB champion could meet 20 new people with TB, and then there would be the follow up also. So, this was one big aspect of their role. Second, they are educating communities about TB, where to seek care, um, not to hesitate to seek care, that diagnostic services are available, where do you have to go, to get an x-ray or to meet the doctor or to give a sputum sample and so on. They're addressing stigma and discrimination, and I think the biggest way in which they're addressing this is just, Sanjana, by virtue of saying we are TB champions. I think that is the biggest anti-stigma strategy that we've really had in this entire 10 years. They're implementing the community accountability framework, and I talk a little bit about this separately. They work very closely with elected representatives, and what we always have maintained is, as an organization, for us to go meet the local MLA or panchayat leader. I mean, projects come and go, organizations sometimes come and go, but TV champions are there, and it's so much more impactful if they do it. Um, as you saw through several short films and articles and videos, really we created this sort of narrative of who a TB champion is, and they're working to strengthen their own networks. On the left is members of the Chhattisgarh network with the health secretary. This was when there was advocacy to increase the Nikshay Poshan Yojana from 500 to 1,000 rupees. And the right is the launch of the Tamil Nadu network. So one of the biggest things that we did as an organization in this phase was what we call the community accountability framework, which centered around TB champions. You could say this was a community monitoring model, but we deliberately didn't want to call it that. I think there's a lot of resistance to the idea of monitoring. So we designed what we called CAF, where a TB champion would use the CAF tool, identify gaps, and I'll show you a little bit of what these gaps could be, and look at ways to address these gaps in coordination with the NTEP by mobilizing resources, with the objective eventually of improving the quality of care and services. We felt that the program was mature enough for a conversation around quality. Know how, yes, services are there, services are being delivered, but how do we talk about what the quality of these services are? And that's what we really tried to do. We imagined CAF as a partnership between trained community allies or TB champions and health staff who were sort of sensitized to this entire process. Now, how it worked is they would meet a person with TB. We defined a particular time point. They should be in their fourth month of treatment, for example. They would ask a few questions. Let's say they would get in that facility 40 such responses. They would collate this and then discuss what we call the block action plan with the NTP staff of that particular facility to look specifically at what could be addressed. And for the CAF tool itself had 5 aspects: timeliness, access, quality of information, attitude of care providers, and attitude of families and communities. And the idea was to really understand what was the experience of a person with TB in terms of all these quality parameters. Just quickly, some excerpts, some kind of questions, so how many days after diagnosis were you initiated on treatment? Was your weight taken at the TU? Were you and your family counseled on cough hygiene? Was the follow-up test done? Was your sputum tested after 2 months? What is the kind of respect or privacy that you had? So each of these questions was asked of a person with TB, and then the information sort of collated and presented in a consolidated manner for that particular health facility. And we did this across 400 plus facilities in 4 districts: Jharkhand, Chhattisgarh, Orissa, and Tamil Nadu, over a 3-year period. I just want to quickly give you the example of, you see this weight case study on the right side. So one of the TB champions discovered in Vellore in Tamil Nadu that weight has to be measured, right, for every person with TB every month, because TB treatment is weight band based. That was not happening. One, there were no weighing machines. Two, there was stigma even at the health facility. So the weighing machines in the general health facility, I mean, TB patients were not allowed to use them. So they realized that by administering CAF, a lot of people were saying our weight was not taken in that particular month. And this then formed the basis for the work that the TB champions did over a 3-4 month period, where they spoke to the senior treatment supervisor. They then took this to the district TB officer at a review meeting and identified what the reasons were. For example, families come to collect medicines, which is very natural, but this means we are not tracking weight gain. We're not able to look at improvements in BMI. So what do we do for this? Can we do house visits? So this became an entire sort of investigation in itself. And I think we had many, many such examples of CAF over the 3-year period. And what we saw in that period was a definite improvement in several quality parameters. For example, the proportion of people with TB who spent money out of pocket after starting treatment came down. the proportion of people with TB who were counseled for HIV or referred for diabetes testing uh, came down. The proportion of people with TB who got their results within 3 days of giving the sample went up. And we saw, we have a more detailed analysis in our report online, which I'm happy to share a link, sort of state-wise, and looking at, obviously this varied across states, across districts, but overall we were able to show that by engaging TB champions, you could look at improving the quality of TB care and services. And of course, there was initial resistance. I remember meeting an STS who said to me, at initially I thought, who are these people to come and ask me what to do? I mean, who is a TB champion to come and tell me why are you not checking the weight of somebody? But as I said, I think as the value of this whole CAF process was established, the fact that they measure quality going beyond standard indicators. It was initially challenging, but over time, people in the health system began to see the value of this. I think even today, if you ask all of us at Reach, this is one of the most ambitious, difficult things we did. And I don't think we'll say we were entirely successful. Today, I mean, CAF did not get adopted by the health system. It wasn't scaled up after the project, but I think it was a intensely rewarding thing for us to do as well. And some key learnings for us from this whole CAF process is that really to look at solution-oriented approach is what the TB champions did rather than a fault-finding approach, is to work together with the health system to address whatever gaps or challenges there might be. And in fact, we heard this from several state TB officers. I'd much rather a TB champion comes and tells me what is the problem rather than read about it in a newspaper, no, or have it escalated. At least this way, I have an opportunity to address something. And it increased trust in the health system. It built TB champion capacity to work with data and to use data for decision making at the local level. And I think it identified latent resources within the community, which TB champions were able to tap, whether it's in terms of buying weighing machines, sticking to the same example, or it's mobilizing resources for additional nutrition support or for employment generation opportunities for TB survivors or family members who obviously had income losses. So there were sort of several latent resources within local communities that TB champions were able to leverage through this CAF process. So CAF was one big aspect of our work in phase two. And the second aspect goes back to the question that Sham asked about um, how did they support people with TB? So one of the ways in we did this is by creating what we called the support hub structure. So as you can see, this is a clinic in Delhi, the chest clinic in Shahadra. So a TB champion would be placed at that health facility. And just like any person who comes in, meets the LT, meets the medical officer, no, meets the senior treatment supervisor, they would also meet the TB champion. And we had a set of things, what they could talk about in the first visit, what they could talk about in the second, and so on. And as I said, we had about 410 such support hubs across 10 states and 82 districts. And through this period, over 4 lakh people with TB got support from from TB champions. And more importantly, we were able to establish an increase in the treatment success rate from 78 in the 2019 baseline to 89% in 2022. Just to quickly show you this, again, this is all in reports online. For example, if you look at Bihar, um, the baseline in the project districts was 67.5%. This is the treatment success rate I'm talking about. And this rose to 87% for our cohort. This is not for the entire state. I want to clarify that. But in West Bengal, for instance, we didn't see any major gain. Rajasthan, we did see an improvement. MP, we did see an improvement. So I think what we were able to establish that, the TB program has diagnostics, has drugs. When you marry this marry good clinical services with good emotional support, that helps improve outcomes. And I think this second phase was also when we really amped up the different training models, not just about that first base survivor to champion. So that was like the basic course, right? The fundamental course that everybody had to do. But other than that, we also developed communication skilling, training on person-centered care, training on drug-resistant TB, on TB and gender, TB and disability, leadership training for survivor-led networks. One thing that I missed mentioning is we also worked with a small group above 40 trans men and trans women who were TB survivors, and we engaged them as champions. And so really looked at, how do we build their knowledge and skills on as many different aspects as possible. Um, two other three things that we also did in this phase. We also tested a model focused specifically on drug resistant TB, where this was in 8 districts of Bihar, where we wanted to try and reduce the pre-treatment loss to follow-up. So we focused on that phase between diagnosis and treatment initiation, and TB champions played a really important role there. We experimented with the Art to End Stigma initiative. And we also developed something called the TB Champion Empowerment Index, where I think what we really wanted to try and measure was the empowerment that TB champions experienced. Now, the treatment outcome, for example, or the quality of care were all a result of the impact of the TB champions' work on either people with TB or the communities. But what was the impact on themselves? And again, this is on our site. I'm happy to share this as well with anyone who's interested. Is we then developed this tool that would measure their own sense of growth, confidence across different parameters. So I think for us, the second phase was really about the consolidation of all of these efforts, was really looking, experimenting with what is the role, what works, what doesn't work. And yeah, it was a very tough 5 years, I will say. But I think we learned a lot as an organization in that period. It was a lot to cover, so I sort of raced over some things. How are we on time? I think I need about maybe 5, 10 minutes for the final phase. I'm wondering whether to show another film or not. Sham, what do you feel?
Uh, as such, we are due for time, but I think we can
Yeah.
be around 5 minutes or so,
Okay,
and
so
then
no, I won't show the film. Let me quickly get through this final phase then, and I can put the link in the chat box. So I think the
sure.
phase three is where we are right now, and it's where we're asking the tough questions. What I've sort of shared so far has painted quite a rosy picture, and obviously it's not so rosy. And so I want to talk about, so what's happening today? Today TB Vijetas, as they recognized by the program. This has been adopted, implemented by various other partners. I mean, for example, there's an organization working on pediatric TB. They've included a TB champion component, looking at pediatric TB champions. Some states like Jharkhand, Chhattisgarh, Orissa have made budget allocations in the PIP for TB champions. There's a lot of discussion going on about compensation versus volunteerism. Just for example, we pay TB champions anything between 6,000 to 8, 9,000 per month during the engagement period, but it depends. It's not, I mean, it's not just a flat amount. It depends on what they do. We've also experimented with sort of results-based, activity-based budgets. Um, and of course, what happens over time when you scale up something is you lose some of these deeper investment. I mean, you can do it with 200 TB champions. You can't do it as easily with 2,000, right? Um, in the health system, when they're getting paid directly, sometimes there can be delays in payment. There's a lot of attrition. There are questions around, so who monitors their work, right? Who do they report to when it's adopted? And then how do they do advocacy with the same group that's compensating them for their time? Is there a conflict of interest there? But then how else does it work, right? And I think, as I said, networks are registered, but they're also struggling for resources independent of us, because our idea always was Reach may leave Bihar tomorrow, but TB Mukt Vahini is going to be there. And how do they no continue to work? How do they raise money? These are questions that we don't really have a lot of answers to. Um, Very quickly, some actions for sustainability that we've done is really building master trainers from among TB champions, networks, like I said, focusing on preventing burnout, looking at self-care, and of course, working with the NTP in terms of how do they engage TB champions directly. In the interest of time, I'm happy to leave this with you all. The last thing I just want to end with, I think a question we're asking ourselves. What is our goalpost for this TB champion movement as an organization, as Reach? When do we say, okay, we are satisfied, okay, we're good to go now, we'll move on to something else. And we don't know that answer yet, very honestly. But I think that's the question we're asking ourselves right now. We've helped create and nurtured this amazing inspirational movement that is in a difficult phase in terms of sustainability. So, what is our responsibility and what is our goalpost? I think is really something that we are trying to address. Um, I will stop here and say a big thank you for inviting me and for this opportunity to reflect on this, as I said, an amazing personal journey for me. And I'll pop this in the chat box for people to look at, and feel free to send me an email, or if you want to look at any of our publications. Let me just stop here, and I'm happy to take questions, comments, reflections, anything. I know that was a lot and I rushed through some of it. A lot has happened in 10 years.
Yeah. Thank you very much. We could see that we could actually see all you are saying that a lot of things have happened. I think this happens with most programs where when you start, it is very intense and very emotional also, that person to person again. And when it goes to scale, this becomes a challenge, how to maintain the same thing. So thank you for sharing all that information. I think it may be of great use to many of us who are working on the ground with TB. So maybe like now we have the session is open for discussion. I request participants to come up with questions, queries, comments, anything they would like to share. Yeah, Kamlesh ji has raised his hand first.
हेलो अनुपमा, मेरा नाम कमलेश है। मैं बीएचएस में कम्युनिटी एम्पावरमेंट का काम देखता हूँ।
Namaste, Kamlesh
और
ji.
जो आपने प्रेजेंट किया, मैं ख्याल से इसी तरह की किसी एक सिस्टमेटिक एक जर्नी की जरूरत थी हमें, मतलब मुझे पर्सनली, बिकॉज हम लोग भी पिछले साल भर से फॉर्मली, मैं तो नहीं कहूँगा कि शुरू किया है, लेकिन हमने फॉर्मली उस पर थोड़ा ध्यान देना शुरू किया है। वो टीबी पीयर सपोर्ट ग्रुप, या जो टीबी चैंपियंस आप कह रहे हैं, जिनको अभी अभी हमने नाम दिया है अमृत बंधु, बिकॉज हमारे क्लिनिक्स का नाम अमृत है और फिर वो उनके साथ जुड़ के काम करते हैं। तो थैंक यू वेरी मच फॉर दिस एंटायर डिटेल्ड प्रेजेंटेशन। मैं अभी भी थोड़ा सा, मैं एक बेसिक सवाल है मेरा कि जैसे हम तो यहाँ पे क्लिनिक चलाते हैं और उससे जो सर्वाइव करके जो लोग निकलते हैं उनके साथ एंगेज करने का काम कर रहे हैं, और आप जो मतलब रीच जो है बेसिकली वो अलग अलग स्टेट्स में जो सिस्टम से रिकवर हुए लोग हैं, सरकार के अस्पतालों से और उनसे उनके साथ कनेक्ट करते हैं।
Correct.
तो वो कनेक्शन कैसे बिठाते हैं आप, मतलब वो कैसे उनको सर्च करते हैं, वो कहाँ से वो लोग आपसे कनेक्ट करते हैं, मतलब आपकी टीम से, एंड देन आप उसको एक नेटवर्क की तरफ लेके जाते हैं। तो एक तो पहला सवाल तो मेरा ये है। और दूसरा ये कि आप अलग अलग स्टेट्स में नेटवर्क हैं आपके। राजस्थान में मैं देख रहा था, तो राजस्थान में शायद नेटवर्क नहीं है, बट उसका इम्पैक्ट आप दिखा रहे थे। तो इस तरह के नेटवर्क से जुड़ने का क्या तरीका है, मतलब कैसे जुड़ा जा सकता है, जो बियॉन्ड दी आपके रीच के बियॉन्ड जो लोग काम कर रहे हैं वो इस तरह के नेटवर्क से जुड़ना चाहें फॉर देयर अपनी अपनी ग्रूमिंग के लिए, और एक सेंस ऑफ बिलोंगिंगनेस के लिए कि हम लोग एक बड़े नेटवर्क से जुड़े हुए हैं, तो उसका क्या तरीका हो सकता है?
Thank you.
थैंक यू।
Thank you, Kamlesh ji. My second question first answer karungi. My Hindi is not very good, so मैं English में answer karungi. Please forgive me. It's improved a lot in the last 10 years of working across states, but I know I'll use the wrong words. So, I think if you look at the networks today, some of them are engaged by us through projects, some of them are not. And I think this is a question we ask ourselves a lot, Kamlesh ji. एक network का long term में, do they have to be, is it enough that they are the peer support? वो बस, I mean, that they are that collective, that they support each other, they raise funds for each other. Is that enough? Or do they have to become financially independent organizations by themselves? Do they have to provide employment opportunities for their members? No, do they have to file accounts every year? Do they have to have audited? No, so I don't know the answer to this. There are 2, 3 of the more mature networks that are doing all of this, but they're also struggling to raise money. And with new organizations, it takes some time to get all the paperwork in place. Also, people move on. आज एक governing body form होगा with 8 people. Of the 8, 4 people may not be there in Rajasthan anymore, right? They may have moved somewhere else. So then what happens to that entity? I don't have answers to this. This is something we're still trying to figure out. Is there any social business model type of no enterprise that we should explore? What does it mean? Is it enough if the network just says, okay, I have 300 members? What does that mean? What does it mean for someone? Because you have to get something back, right, from being part of a network. Why do you choose to join a network otherwise? During your treatment, you can get the support, but then what is the long-term value for someone of being part of a network? And it's not like, again, the HIV example, right, where you continue to need that support. So then what is in it? So these are also questions we are really struggling with. I don't have answers to your questions entirely. To your first question about, so we work almost entirely with public sector systems. So let's say बिहार में 8 डिस्ट्रिक्ट में हम एक प्रोजेक्ट करेंगे. We would go to the Bihar state TB cell, discuss it with them, discuss it with the district TB cells, and officially get permission for TB champions to be placed at those facilities. How do we identify new TB survivors? Sometimes it's through the network, it's through word of mouth, it's through the health system, it's through PLHIV networks, it's through NCD networks. I mean, I think, over time expanded this, no? And therefore now, I still remember in 2016, it took us 4 months to get 25 names in Bihar. Today, I can tell you it will be no, it can get find 50 new people in 2 days. But that's where that I think building that credibility and building that sort of recognition that today, if TB Mukt wants to find 50 new TB champions, they can easily find it from among their members. They don't have to go around no asking people to get involved. I hope I've answered your questions. Thank you.
Thank you. Thank you.
Any other questions?
Maybe I'll come in.
Yeah, sure. Yeah.
एक तो I think Kamlesh also asked, how do we connect to TB champions? I think one way to connect is, Anupama, to invite you here to.
Oh, so
And-
sorry, I misunderstood the question, Kamlesh ji. Sorry. How to connect to TB champions? Rajasthan specifically, I can send you some contact details. I'm not sure which districts they are in, but I can send you. Usually it would be through the network. So in Tej, for example, no, I would give you the email IDs or phone numbers of the Tej office bearers. I think that's the most useful way to sort of connect. So I'm happy to make that connection. Sorry, thanks, Sanjana.
No,
My
the idea was
Hindi
also to.
comprehension failed
हाँ,
me.
still अनुपमा जी आपका आना अच्छा रहेगा.
हाँ, बिल्कुल.
That was what we were trying to use this point for. One question, Anupma, is that when we talk of primary healthcare, we talk of this being the space where one can work on empowering communities in addition to services and address the determinants of health. So did you see any difference between the influence of the TB champions if it was happening at a large hospital or happening at a primary care level?
By coincidence, or I mean, it wasn't by design, but because a lot of our work has happened in the rural areas of Bihar, Jharkhand, Chhattisgarh, Orissa. Um, we didn't go in with a primary care design, but that's how it panned out, and again, though, I must clarify, is because we work so closely with the health system. So TB champions have ended up being placed, let's say, at the district TB center, for instance, right, or the nodal DRTB center. But, and this is what is important, is they are people from that area. So I think what happened is over time, the sphere of influence, if you can call it that, for a TB champion became not just the facility, but became the village that they lived in and adjoining areas where people came to know that here is this TB champion. Um, I think in cities like Patna, where we had more urban interventions in a Patna, in Bhubaneswar, in Raipur, maybe what happened is a little bit of this community sense was lost because it was limited to the that large tertiary hospital or health facility. And I think that's the only change we really saw is because let's say we have a TB champion who's in Patna, who's not from Patna, but who's come there for work or various other reasons. So their sense of community is different in that urban setting, or if they're a migrant themselves from some other state. So I think that's really the difference we observed from between a primary care setting, that's sort of closer to communities to sort of more tertiary care settings, really, is that's sphere of influence. Thanks.
Thank you. Okay.
Any other questions? I've just put into the chat box a couple of links. I'll also add a link to all our publications, including many about TV champions, which are, in case anyone wants to take a look.
Anybody, any other comments, questions? Okay. I think, yeah, please go ahead, please. Yeah.
हाँ, तो मैं बस एक और चीज जो जस्ट थोड़ा सा हमारे अपने मतलब अपने लिए पूछना चाह रहा था कि जो मॉड्यूल्स आपने बताए थे कि वो जो 3-4 तरह के जो मॉड्यूल्स हैं डिफरेंट उनकी कैपेसिटी बिल्डिंग को लेके क्या वो मतलब किसी तरह से हम उन तक पहुंच सकते हैं या मतलब क्या तरीका है कैसे हम अपने लिए अपने ग्रुप के लिए भी यूज कर सकें दूसरा और ये जो केफ वाला जो फ्रेमवर्क था वो थोड़ा सा प्रेजेंटेशन में थोड़ा सा क्विकली हुआ तो थोड़ा बेहतर समझना चाहते हैं तो हु विल बी द राइट पर्सन और प्लेटफॉर्म जहाँ पे हम ये थोड़ा सा और ज्यादा एक्सप्लोर कर सकें
बिल्कुल सो करिकुलम एक्चुअली पूरा करिकुलम ऑनलाइन था बिकॉज इट वाज officially adopted by NTP. My link I'm just searching for. I मैं डालूंगी. I'm happy to send you the link by email also, Kamlesh ji. CAF, feel free to write to me. Like I said, it ended with a project, but I'm happy to share our experience and if it's something. Oh, and we have all the tools in Hindi also because we use them in Hindi speaking states except for Orissa and Tamil Nadu primarily. So happy to share that if you're interested.
थैंक यू
Curriculum का link मैंने chat box में
Yes, it
This
has
is
come.
This
Yeah.
is the older version. This is the original 2019 version, but I mean, the bulk of it remains the same. Only the TB technical aspects and no the new aspects in the policy and the program that alone we have updated. Otherwise, this can be used.
Okay. So if there are no other questions, I think we can move on to conclude the session. Uh, Thank you once again, Anupama ji, for this session. It was very useful. I think with this, our government's goal of eliminating TB by 2025 was a very difficult thing, and all of us knew it, and we could not achieve it. Now, I think is the time to reflect and to find out ways in which we can do this. I think this is a very good and a very potential intervention which can be useful. In fact, we had been recently having sessions on TB. The previous session which we had was also on this TB risk calculator. So that was also, I think, very useful. So and this TB champion movement. So I think these are some key interventions which can be useful for people who are working on TB. So that way it falls in context in a very great way. So thank you. Thank you for the time. Thank you for coming and sharing your work and all the resources you shared. I think we would like to stay connected with you in whatever way possible, and maybe take your help also in future. So with that, maybe we can conclude our session. Sanjana ma'am, you want to say anything? Want to add anything?
No, I just echo what you said, Sham. I think TB needs so much. I think TB care is not possible with medicines alone. It as important as the medicines is, the person's own involvement, community participation, and what we have learned today is one really powerful way of making it possible. So thanks so much, Anupama. And yes, we are going to come to you and, seek
Most
you.
welcome. No, thank you so much for this opportunity and for inviting me. Really wonderful meeting all of you. And I hope to visit and see your work in person and learn from you as well.
Wonderful. It will be a mutual process. Look forward.
Absolutely.
Yes.
Great. Thank you so much, everyone. Wonderful
Thank
meeting
you.
everybody. Thank you.
Okay.
Bye.
Okay. Thank you so much. Yeah. Bye. Bye.